I can't tell you how excited I am to have everybody show up Friday at 7 o'clock for an imaging poster discussion at San Antonio Breast Cancer, especially after the big party last night. We didn't check to see who had used their drink tickets or not, but maybe that might have been important. Those people will probably come a little bit later. I'm David Mankoff from the University of Pennsylvania. I'm delighted that this is our third year in a row of having an imaging-focused spotlight. This will be a really interesting spotlight that will be at the intersection of molecular imaging, primarily estrogen receptor imaging and AI, with at least one transition poster. So to keep this moving, the format is going to be that our discussants will give about a 15-minute presentation summarizing the posters and putting them in the context of what's going on in the field. We have all of the presenters up here, and then we'll have a 15-minute Q&A regarding the presentations and a discussion. I will warn you that if you don't come up for questions, you're going to have to listen to my questions, so that's a good encouragement for you to come up. We also have the opportunity to have questions online that will contribute as well. And so without further ado, it gives me great pleasure to introduce Laura Kenney from the Imperial College of London, who is going to serve as our discussant. Many of you will know Laura, who's done outstanding work in the field of molecular imaging as a breast oncologist. And Laura, the floor is yours. Thank you. Thanks for doing that. And I think the timer's right there.
Okay, I'd like to thank the organizers for inviting me to review these interesting abstracts today. Here are my disclosures. So just a little bit of background to begin about FES. So FES PET was initially approved in the US in 2020 for metastatic or recurrent breast cancer. It's a fluorine-labeled estradiol, and it binds to the ER receptor in the nucleus of ER-expressing cells. What we need to remember is that the presence of the ER receptor doesn't always equate to ER sensitivity, and the real focus of FES imaging is on the detection of negative, low, or heterogeneous uptake. We have different washout periods prior to FES for different agents. So for example, tamoxifen is 8 weeks. Aromatase inhibitors, there's no washout required because they don't interact directly with the receptor. Fulvestrant is 28 weeks, elacestrant 11 days, and it's unknown yet what the washout period will be with respect to FES imaging for new agents. Generally, an SUV max of 1.5 or more is considered positive. One of the intriguing things is the reasons for FTG discordance, and that's what we're trying to detect, lesions that are no longer ER positive. It's particularly promising in bone disease, as bone biopsies may lose ER expression due to sample preparation with decalcification. Some important limitations exist with FES imaging, including high uptake in the liver, ER-positive non-breast entities such as the uterus, fibroids, meningiomas. We also see moderate ER expression in the normal lung and an atelectasis and post-radiation pneumonitis. So this illustrates tumor heterogeneity. So we can see here that FDG and FES are completely concordant. In the second panel, we've got some discordance, and in the final panel, there's complete discordance with FES-negative lesions. Some of the key studies so far have shown us that high baseline FES can predict for response to tamoxifen in metastatic disease. FES uptake can correlate with ER expression by immunohistochemistry and tumor size. Negative or low uptake can predict for early progression. The Dutch group have shown that time to progression of 73 weeks in lesions that are completely FES positive, and that compares to those with FES negativity where the time to progression was only 15 weeks. Another study published this year in the Annals of Oncology divided patients into high and low uptake cohorts. Those with a FES uptake greater than 2 were treated with endocrine therapy and had a prolonged median overall survival. Less than 2, patients were randomized to chemotherapy or endocrine therapy, and as you might expect, FES-negative patients did a lot better on chemotherapy. And this just illustrates some of the findings from the Dutch group. Here is a FES-negative patient who was a non-responder. A set of appropriate use criteria have been published by Ullner et al. in JNM last year. The most promising indications appear in lesions that are difficult to biopsy, detecting ER status when other imaging tests are equivocal, at initial diagnosis or progression of metastatic disease. We're now in an era of rapid development of endocrine therapies, and it's very important that we have a good biomarker that can predict sensitivity. So the first abstract I'd like to discuss is the EA1142 study, which looks at FES-PET as a predictive measure for endocrine therapy in patients with newly diagnosed metastatic disease. This was work performed by Hannah Linden and Dave Mankoff. And in this study, patients had a FES-PET scan at baseline with clinical follow-up at 6 months and 2 years after treatment with endocrine therapy plus or minus a CDK4/6 inhibitor. The primary objective is to determine if the negative predictive value of FES-PET for response at 6 months. Secondary objectives included retest, reproducibility to determine accuracy for predicting response and progressive disease, and look at the optimal cut point for FES-SUV. Most of the patients in the study had polymetastatic disease, with 85% with more than 5 lesions or more, and the disease was predominantly located in the bone, with 58.2% of lesions located there. The median uptake per lesion was 6.6, and on a patient level, this was 6.7. It's interesting to note that 0% of patients had no uptake at baseline, and very few actually had minimum or mild uptake in the study. So the poor radiologists had to identify 450 lesions in this analysis, so it was quite a lot of work, and 262 of these were located in bone. Most patients were postmenopausal. Most of them received an AI with a CDK4/6. There was a wide range in FES uptake. 19% had qualitatively no mild or moderate uptake. There were no patients that had an average SUV max less than 1.5. 16% progressed at 6 months and 64% at 2 years. Of 4 patients with heterogeneous uptake, 25% progressed at 6 months and 75% by 2 years. A further analysis using FDG did not identify any additional FES-negative lesions, and FES-PET was reproducible. So this just summarizes those results. This is a typical FES-PET scan. I draw your attention to the high uptake in the liver, and in the 10 patients that had the retest study done, it was highly reproducible. So in conclusion, patients undergoing first-line therapy for ER-positive metastatic breast cancer were evaluated for ER expression with FES-PET. The negative predictive value couldn't be assessed due to the low number of FES-negative lesions and low rate of progressive disease. This was not anticipated from previous studies. Retest show excellent qualitative lesion reproducibility of FES-PET. The second study is by Dr. Bidard et al. Of the French group, using FES-PET to guide second-line treatment decision in patients with ER-positive, HER2-negative advanced breast cancer progressing on first-line AI and CDK4/6 as part of the Institut trial. So in this, patients had an FDG PET scan, then their oncologist formulated a management plan before a FES-PET. They were given the results of the FES-PET scan, and the study was to see if the management plan changed following the FES-PET results. The cohort is interesting in that the majority of the patients actually had de novo metastatic disease, which is slightly unusual. They were postmenopausal. Most patients, compared to the previous study, had polymetastatic disease, and a lot of the disease was located in the bone. So in the top panel, you can see where the FDG and FES-PET are concordant, so no treatment change was initiated. In the second panel, we see discordance, and following this result, the patient was subsequently treated with capecitabine. So FES-PET changed management in 36.7% of patients. In 17 of 19 patients without changes in management, the oncologist thought FES-PET was helpful. 2 patients, the treatment wasn't changed even though there was heterogeneous disease, and these patients progressed earlier. Further analysis is required on the final data set, and In summary, therapeutic management was changed in 67% with lobular cancer and 28.6% with invasive ductal CA. So you can see, compared to the previous study, there's quite a lot of heterogeneity in this cohort, and also the 4 out of 30 had all lesions ER negative, where we had 0 out of 100 in the US study. So this is the first study to document the utility of FES-PET-CT to inform therapeutic management post-CDK4/6 disease, and this is a real vacuum in our knowledge space at the minute. We need further analysis. FES-PET showed lower pain and apprehension scores compared to biopsy, which is unsurprising in our view. The next study is from the Dutch group, and this is a comparative analysis of FES-PET and FDG in patients with metastatic invasive lobular cancer. And patients had FDG PET, FES-PET, CT, and bone scintigraphy. So I congratulate the authors on getting patients through 4 sets of scans for this study. So 12 patients showed more avidity on FDG, 12 patients showed more avidity on FES-PET, and in 2 patients, the METs were equally visible. And this just summarizes the results. So here we can see more lesions visible on the FDG compared to FES, and here the reverse is true with more lesions visible on FES compared to FDG. In summary, 81% had more lesions visible on FDG, 78% had more lesions visible on FES. Most of the disease was bone predominant. FES-PET was superior in identifying lymph node metastases. Sorry about the small text on this slide, but if you care to look at it afterwards, you will find that the worst scan was actually CT scans, closely followed by bone scintigraphy compared to the FDG and FES-PET. So in summary, FES-PET doesn't outperform FDG-PET. The 2 techniques have similar sensitivity on a group level. For clinical practice, we would still recommend FDG as it's more widely available, but in a small, considerable number of patients, we would say that it may help determine further therapy, so it should be considered in patients with metastatic invasive lobular cancer. The final abstract confirms a radiomic analysis of patients who underwent dynamic FES-PET imaging from the Penn group. Patients had a lesion size greater than 1.5 centimeters, liver-only disease was excluded, and they had dynamic imaging from 30 to 60 minutes with 3D masks. So this really reflects intratumoral heterogeneity. Our previous studies have really looked at the heterogeneity between different lesions within the same patient. So they're able to do hierarchical clustering and tumor segmentation. And the results were positive. The 4D features found a significant difference between overall survival for the high or low risk group, and this incorporated some clinical features as well. The most significant radiomic feature was tumor subregion distance, and this does reflect intratumoral heterogeneity. So in conclusion, FES-PET's well tolerated. These abstracts certainly do add to our knowledge about the utility of FES-PET. It does have a potential as a pharmacodynamic marker for new ER-targeted therapies. Lack of ER expression should prompt us to think about other therapeutics. And further studies, I think, need to combine other markers of ER resistance. Radiomic work looks promising. Should we carry on with bone scintigraphy? My other question is, do we need a different cut point for our FES between high and low? We're now starting to use whole body PET a lot more, which is much more sensitive, and we may see even more improved results with that. Can we look at shorter washout periods? The one with fulvestrant is really much too long for oncologists. Just some points of note, we do see false negatives with small lesions or those near the peritoneum. If the FES-PET result is less than 1.5, then there's an 88% chance of treatment failure. Should we have different treatment for heterogeneous populations? If we have incomplete ER blockade, that may mean that the patient's going to be an early progressor. What's the utility of FES-PET? So the SONIA trial has been presented recently, and it was also published in Nature this week. which shows that the difference between first or second line CDK4/6 inhibitors was insignificant and actually results in less toxicity. It's a standard treatment for most of us, but perhaps if we did a FES PET and showed a small number of bone lesions, we'd be happy to treat that patient with endocrine therapy alone. Or if it revealed more lesions than we were aware of, then we would want to use a more intensive therapy. We know that even though the ER is positive on a FES PET scan, it doesn't always mean that patients respond. However, things that can affect ER response, such as mutation of the ESR1, do not affect FES uptake. Functionally, the ER, although positive on a FES PET scan, can be negative. We can also have issues with heterogeneity, which is the most important feature with FES PET scans. The studies so far haven't really looked at other things that contribute to endocrine resistance, such as P53 and PIK3CA mutations. I think there's a real need now for us to combine genomic data to form imagenomics so that we can look at ctDNA for PIK3CA mutations, ESR1 mutations, to build up a better predictive marker. This is an example of elacestrant with FES PET showing complete blocking at 14 days. And we may need to use this for some of our novel agents to assess utility. What do I need as an oncologist? Well, I really want to know what's the right therapy post-CDK4/6. I need better biomarkers to determine who will benefit most from adjuvant ribociclib, better imaging and staging of ILC, so we need further large studies with FES PET. The following studies are currently ongoing, and I'm going to leave with the final study, which is planned by the University of Washington group, to look at FES PET randomization to determine treatment for patients with bone and soft tissue dominant metastatic disease. Many thanks.
Thank you, Laura. That was an amazing amount of information and summary with background in only 15 minutes. That's impressive. Before we start the Q&A, I'd like to have the panelists introduce themselves. Francois, maybe if we start with you and we'll come down the line, just introduce yourself and where you're from. So. You can just stay at the desk and just speak into the microphone. It's just a discussion, just for question and answer. I just want everybody to introduce themselves, that's all. Yeah.
Okay, so Francois-Clement Bidard, so medical oncologist at Institut Curie, and trying to navigate with biomarkers.
Great. Hannah?
Hannah Linden, University of Washington, and the Fred Hutchinson Cancer Center.
Jasmine?
Hi, I'm Jasmine Moustaquim. I'm from the Netherlands, from the Netherlands Cancer Institute and the University Medical Center Groningen.
Hi, good morning. My name is Dr. Carla Zeballos Torrez. I'm from the University of Pennsylvania.
And the only one correction I need to do on your slide, I think it's Dr. Zeballos Torrez that did the last presentation. I think you had given Dr. Bidard credit, and maybe he would like it, but it was from her. So if you have a question, please come ahead and go to the microphone. Folks that are online can also ask questions from there. I will start with a moderator question. Pretty much all of you were doing FES studies, but we're also doing FDG. So question to the panel, should we be doing an FES without an FDG for prediction? Let me start there and give Hannah and Francois a chance to ask that.
So in the context of Astro team, so clearly we are seeking for the few patients, or we know that about 10 to 20% of patients may have a decrease or a loss of ER expression in their metastases. That's a mechanism that is a kind of universal mechanism of endocrine resistance, and it would have a major implication on whether the second-line endocrine treatments could be useful or not for the patient. So we are definitely seeking the FDG plus FES negative, and so that's why we single FES PET in this setting would not be relevant. Again, seeking for this patient whose tumor has lost ER expression.
Yeah, it's very interesting. It's really hard to know what you're missing if you don't have another scan. And the biology works such that glucose metabolism seems to be reliably elevated in the other folks. Hannah, if you want to go next, and then I did want to ask that from Jasmine's standpoint as well.
Yeah, I think that actually the next poster shows that you need both. I I have ordered FES without FDG in a, metastatic primary intact lobular where, I sort of have the positive control. But I think that without FDG, you can't compare and you can't determine if a particular lesion is negative. And it's not about all lesions being negative, it's about any lesions being negative. So if you don't have that denominator, I think you're lost in analysis.
Jasmine, what about from the staging standpoint? You look like you had complementary performance in your study. Yeah.
Sorry?
What about from the staging standpoint? You
Yes.
looks like you had complementary performance of FDG and FES in your
Yes,
study.
so yeah, we looked into, we actually looked into the impact data in which 200 patients were prospectively enrolled of all subtypes. But in our poster, we only looked at the lobular breast cancers. And for staging, indeed, we did see that the FES PET did not outperform the FDG PET. And yeah, our advice would actually be in some patients that you could perform an additional FES PET next to the FDG PET. And that would be of interest in patients in which there are clinical dilemmas or maybe there are lesions of which are doubts. Is it metastasis from the breast cancer? And then the FES PET could give you some additional information on that. So I agree with you that it would be complementary. So it would be better to have an additional FES PET, but not start with that upfront. Yes.
Thank you. Carla, we'll come back to you with a later question. We'll go to the audience. I'm going to go to my left over here.
Hi.
Please introduce yourself and ask your question. Yeah.
Elisa Krill from University of Miami. My question is, if you have somebody with a FES PET that has one or two areas that are not uptaking the same as on their regular PET, their FDG PET, would you change their therapy? Would you shy away from hormonal therapy as a first-line treatment? And conversely, if you have somebody with oligoprogression and you do an FES PET and the one area of oligoprogression is no longer positive, but the other areas are, would you radiate that one area and continue the hormonal therapy if the rest of the disease is not progressing? And just a comment, in the state of Florida, I don't know if it's everywhere, we have trouble getting PET scans. Our insurers want us to get CAT scans and bone scans in many cases, which are I think, very inferior for evaluating bones especially. And I don't know if there's something we can do with advocacy with the federal government. I think it's a big problem in oncology. It wastes patients' time, doesn't give us enough information. And I think as a society, we should advocate for better payment for this.
Yeah, so I'll editorialize on that. Jennifer Specht is in the room, who's one of the people running a prospective ECOG-ACRIN trial that's ready for readout, designed to, we waste time in Pennsylvania and New Jersey as well in that same process. Let me go back to the question. Francois, I think you had heterogeneity in your study. Would you choose not to treat, these are second-line patients, based upon the heterogeneity that you saw?
Yes, so in our team, so in the study we are presenting, so yes, we are, let's say, looking at the impact. So oncologists could decide, or radiation oncologists could decide on treating like these patients in these few cases where you see like, let's say, an oligo discrepancy with some few lesions having lost the ER. We definitely need to, that's a huge potential for the FES PET to highlight like these few lesions that could have become endocrine resistant. So I think there's a huge potential when it comes to the evaluation of this strategy, whether we should do it or not. That's a bit tougher because it's very heterogeneous. So I would say at the moment I would accept it in my standard practice. If it could happen that I would do that in some patients because it kind of makes sense. But I also acknowledge that it's not enough from a scientific perspective. It's not very satisfactory. So we are currently trying in another trial, which is a second-line trial. That name is Eclectic, and we are, again, navigating the patient. It's very similar to the trial you showed. It's posed the question of chemotherapy versus endocrine therapy in the second-line setting based on FES PET, and we are allowing patients to be treated with endocrine therapy, even though they have a few number of metastases that are FES negative, as long as these lesions are treated with the local treatments, which will be radiation therapy. So obviously, there won't be so many patients, but we'll be able to document a bit what is the outcome of this patient under endocrine therapy as part of a prospective trial.
And there are clearly international and national trials going on testing the second line of this to provide more evidence. Hannah, quickly, could you also comment on that from the first line? We have one more question. I want to make sure we get to it, but a quick comment on the first line question.
I think we don't know what is the best strategy, but I would argue that when you see that change, that's the tip of the iceberg, that the tumor is changing, and it's a systemic disease. So you can radiate those lesions if you want, but the next lesion that pops up is going to be ER negative. So I would change therapy personally, but I don't think it's wrong to treat oligoprogression in these people who have very indolent disease that isn't moving fast. We all know that you can sit tight, but I think what you're going to get is stable disease out of the other lesions, and eventually you're going to still have the problem. So the other strategy would be to consider biopsying one of those lesions to see if there's some other target for you. But I think what the data we saw from Jasmine's poster is that changing treatment, changing systemic treatment might be a good idea. But I think this is unknown, so it's great that we're doing this study so that we can sort this out. I guess what I'm thinking is that the imaging shows you a lot, but it doesn't show you everything. You can't see the micromets, the little seeding of the peritoneum, and all the little other things that are going on inside. And so I think it's giving you the tip of the iceberg and telling you something's wrong.
Thank you. And I think there's a lot of data to come. I will point out that one of the appropriate use criteria is directing biopsy to these ER negative lesions. Yes, on the right. You've been very patient with us. Thank you.
Yeah, Dr. Akhtar, King Faisal Specialist Hospital, Saudi Arabia. Thank you for the nice talk. I have a few comments, and if you can elaborate on this. What about the society guideline about the uniformity of isotope production? Like the uniformity of every institution is going to produce it the same way? Second, what about the acquiring images? And the SUV cutoff, what is the guideline? I mean, you choose one, I can choose the other one. What is the society guideline? Reporting guideline, that how you are going to report it in the absence or the presence of generic PET scan. And what about the cost effectiveness? Having said this, I had a patient with simultaneously renal cell carcinoma. So it really helped me to identify that the lesion in the lung is coming from the estrogen related tumor. So we were able to differentiate. So it really helped, but limitations are still there and the field is evolving.
Yeah, so I'm actually going to take prerogative to answer most of that question. On the guidelines for this, much of what you asked is actually in a paper where I'm the first author that was both the European Society and the Society of Nuclear Medicine. Almost all of your questions are answered there. I think what's the right cutoff right now is a debate we could spend the rest of the morning on. I probably won't. But I think that's an area that we're going to try to evolve more studies, and it may depend upon what you're looking for. Uniformity of production is tricky. We actually spent a fair amount of time on this in the production of the approach, and because it's a receptor agent, it has more quality control. There is a commercial supplier in the US, there's a commercial supplier in Europe. For folks that are outside of that commercial supply distribution, there are actually pretty good guidelines on what the quality of the product should be and what its molecular compounds. And I'm very happy to talk to you at the end of this talk about that offline. Any further comments on that? I think this is going to be something that will be the subject of future debate, but I wanted to point you to that article, and I can show you the Journal of Nuclear Medicine only gives us a little postage stamp, but you have to click on that and it'll take you to the full paper. So thank you for the question. I did want to we have time for one more question, and I wanted to start with Carla on this question is, there's information on biology here that we are ignoring, and maybe you could comment on the approach that you've taken and to the extent that they may reflect new biology that we haven't looked at.
Sure. So the approach that we've taken was previously tested on FDG dynamic PET imaging data sets, looking at the voxel and the time activity. And that's what we've done with our FES data set. And it does tend to show a bit of a different biology. And I don't have an FES and an FDG PET images to compare the two, but it certainly would be nice to have something in the future to see how heterogeneous the tumors are in terms of the ER expression and the FDG uptake.
And I'll leave that as a little bit of a segue to our AI that will follow. And a point that these are dynamic scans, so you don't usually do that in the clinic, so it's a question. We have time for maybe one more quick question. Thank you.
Thank you. I'm Diana Mandras. I'm a patient advocate with lobular breast cancer. And I actually have FES and FDG PET scans run this year. The tumor was ER/PR strongly positive, HR2 low negative. Both PET scans don't show any intake of the tracer. So I think this is the case where maybe the tumor changed now and it's not the hormonal tumor. So what would you recommend in this case? Running one of the blood tests, CD blood test, or doing a new biopsy? And I still have the tumor. So I was diagnosed 2 years ago and I choose not to have the surgery.
Yeah, I just want to make sure when we comment, we're not commenting on individual cases. So I want to be careful there because none of us are licensed probably in the place where you practice. Maybe one quick answer, Jasmine. How do you think about lobular in your cohort? Are we missing patients or others? I just want to do it quickly so we have a chance to.
Yeah, well, we know from lobular breast cancer indeed that it has an infiltrative growth pattern, so it's quite hard to recognize on a lot of imaging modalities. And I just wanted to ask, do you have any primary?
I think I want to be careful not to go in that direction, and we're running out of time, so maybe just a quick comment, and then you both can chat afterwards. Perhaps.
Yeah, I was wondering if you had metastatic disease or the primary tumor. But in this case, I think it's good to try to combine different approaches. We have the CT, maybe an MRI. It's good that we try the FDG and the FES. But indeed, maybe liquid biopsies or CT DNA testing could lead to some more clues on which the treatment could be.
And you've got a number of experts on the panel in the audience. We'll take that one offline if that's okay. But thank you very much. It's really a problem that everybody is very actively studying. I want to thank Laura and the panel for great presentations. You guys get to sit down, and Aimilia and the next group get to come up. So. And as we're switching from the molecular imaging to the AI portion of the study, I want to thank Fred Howard, who co-organized this session with me. He wasn't able to moderate with me today, but he really managed the AI piece of this that will come. So all presenters, Graham, come on up. Everybody should come up. Graham, can we bring you up as well? Okay, Reshmi, you're not the presenter, I'm sorry. Yeah. Okay, so we're going to go through the same process. It gives me great pleasure to introduce my former colleague now at WashU in St. Louis, Aimilia Gastounioti, who is an assistant professor of radiology at WashU, already one of the leading experts in the application of AI to breast cancer and breast imaging. And thank you for being today's discussant.
Thank you so much, Dave, and thank you so much for the invite to be here. Good morning, everyone, and many thanks to all of you for being here, especially so early. So here are my disclosures. Okay, so I will start with a brief introduction to computational imaging analytics at a very high level and AI, since this is going to be the common topic and focus of the studies that we will be discussing for the rest of the session. So I think that you would agree with me that although certain imaging biomarkers are relatively simple to extract, for example, here on the top right, we see the tumor volume and measured, over time in different exams. So even for those relatively simple biomarkers that we get from imaging, still computation and automation is key towards higher robustness, reproducibility, and accuracy. But most importantly, modern breast imaging nowadays is quite complex and contains a wealth of information with multiple imaging modalities involved, and that certainly offers unique opportunities for discovering novel imaging phenotypes for different predictive and prognostic applications. So AI has certainly led major advancements towards this direction, starting with more traditional, I would say, machine learning models that leverage the potential of radiomic or what we call engineered features by merging them into powerful predictive or prognostic phenotypes. The latest revolution, though, as you may have heard a lot in this conference as well, has been driven by the introduction of deep learning, which compared to radiomics has this unique advantage of ingesting images directly without an explicit feature conversion. And that figure on the right of this slide basically shows once again that deep learning is really one technique belonging to AI or machine learning, but we often refer to these three terms, AI, machine learning, deep learning, often almost interchangeably. So the great potential of AI has brought it certainly into the mainstream in several medical imaging applications, including, of course, breast imaging, which has been at the forefront of AI developments, and that includes several applications that aim to improve both accuracy and efficiency in breast cancer screening, diagnosis, and prognosis. And in this slide, you see some of those applications in screening, for example, including breast density assessment, assessment of risk of future breast cancer development, assessment of masking risk. Then the diagnosis space, we focus a lot on detection and segmentation, as well as identifying molecular subtypes of tumors via AI. And of course, in the prognosis space as well, lots of work happening in treatment response, prediction, recurrence, as well as mortality. So in this session, we have 4 wonderful studies which tackle some of these applications, the one that you see in bold face here, namely breast cancer risk assessment, detection, as well as studies on treatment response prediction and prediction of breast cancer recurrence. So let's dive into that, starting with our first poster by Poornima Saha from Endeavor Health. So this study aimed to predict recurrence in HR-positive, HER2-negative breast cancer patients undergoing endocrine therapy with or without chemotherapy using pretreatment DCMRI. The study leverages AI in 2 actually different ways. First, for automatic segmentation of the tumor as well as the surrounding vasculature. And then AI is also used to fuse MRI features into a prognostic model for recurrence-free survival prediction. So specifically, the MRI features that came up as most powerful here were morphologic tumor features as well as vascularity density in the tumor surrounding regions, as you see here in the center of the slide. So this model was trained on 522 patients and then validated on an independent set of 550 patients. Both data sets came from multiple sources, which I think was a unique advantage of the study. And based on the authors' updated results on the validation set, the 5-year recurrence-free survival for women predicted as low risk by the model was 93.8. Compared to 82.6 for women predicted as high risk. And the adjusted hazard ratio for the predicted high versus low recurrence group was 3.1. You see here a bit of small fonts. So this prognostic signature was added to a clinical-only risk score, both as a continuous variable as well as a risk category, with significant improvements in prediction as indicated from the reported likelihood ratios. So the model was also prognostic regardless of nodal status, age, and therapy sequencing, as shown by various subgroup analyses reported by the team in their abstract. So our next study is from Reshmi Patel from the University of Texas at Austin and is also on the breast cancer prognosis space. Specifically, this study focuses on treatment response prediction in locally advanced breast cancer patients undergoing neoadjuvant therapy using pretreatment MRI. This study leveraged really a mechanism-based mathematical model that captures tumor heterogeneity and predicts tumor response to therapy at the individual patient level. Briefly, the mathematical model that you see summarized here is a partial differential equation characterizing the range of change in voxel-wise tumor cellularity as a function of cell movement constrained by tissue, mechanical properties, and as well as logistic proliferation and death due to the response to therapy. So this is applied at the apparent diffusion coefficient maps obtained from the diffusion-weighted MRI scans after various steps that are summarized in this nice figure of the abstract that basically involves various steps of intra and inter-scan registration. So this pipeline was previously developed by the team and is validated. The pipeline is presented and in more detail in this paper here of 2022. So in this study, this pipeline is validated to the multi-site, multi-subtype data set of the I-SPY2 trial. So specifically for a cohort of 91 patients, the model was calibrated to MRI exams that are required pre-treatment, which is here marked as V1, as well as early in treatment, which is marked here as V2. And once the model is calibrated, it's tested in predicting the tumor status in V3, which is the time point after 12 weeks of treatment. So here are the results on this independent data set of 91 patients from the I-SPY2. In A and B, we see the concordance correlation coefficient between the observed and the predicted change at this time point V3, which was 0.94 for the tumor cellularity and 0.90 for the total tumor volume. And then as you see here in the figure C, for most of the patients, about 70% of the data set here, the median absolute difference between observed and predicted % change in tumor cell distribution was less than 10%. So very promising results. And I think there is also a paper from the group that just came out 2 days ago at RAD-AI that shows an extension of this pipeline with deep learning as applied to triple-negative breast cancer patients. So very exciting results. Going to the third study here, the goal was breast cancer detection and five-year risk assessment from the same model, which relies on a multimodal transformer fusing one, longitudinal imaging data, but also multiple imaging modalities, and that involved mammograms, 2D, 3D, ultrasound, and MRI. This is a study from Yang Hu from NYU. So again, as we see here, basically where the model is merging longitudinal data, but also multiple imaging modalities acquired over time. And briefly, what the model does, it relies on some modality-specific feature extractors, which are then tagged with important variables such as age, the type of the modality, the study date, and the view. And then this combined information is given as an input to the transformer encoder for cancer prediction. That in this case is basically, the model provides two outputs, both the probability of having the cancer already present, but also the risk of developing cancer within 5 years from the last exam. So for a bit more context, just very briefly, this team has showed that before that this model is actually a better way to combine multiple modalities than, for example, single ensembling models. And that was a work that published last year that showed, again, longitudinal data. At the time, it was only mammograms, 2D, 3D, and ultrasound. And those previous results showed a benefit both in cancer detection, but also 5-year risk assessment with significant improvements in the predictive capacity. So in this study, the main presented here, basically, it's the same data set used in the previous one, which is a uniquely large data set of more than 1.3 million exams from more than 300,000 patients. And the novelty is the addition of MRI to the multimodal transformer. So the team shows that by adding MRI in prior exams, both cancer detection and risk prediction were improved. Specifically, the model achieved an AUC of 0.94 for cancer detection and 0.85 for predicting 5-year cancer risk. And there was an additional interesting analysis that I also discussed with the first author, and I think it would be a nice discussion in our Q&A as well, that showed that also including prior imaging enhanced the effectiveness of MRI alone in detecting cancer and predicting risk. And that was a comparison with a unimodal network relying only on MRI at the current exam. Last but not least, the study by my colleague Joy Jing from WashU Medicine. This study is also on 5-year risk assessment, but here with a focus on women with high breast density. The tool is a dynamic mammogram risk score based on at least 1 and up to 4 consecutive mammograms, as you see here in this figure. So this tool was previously developed by the team using a WashU cohort and was also validated on data from the Emory University. That was a journal paper that just came out earlier this week. So the development cohort was around 11,000 women. The first independent validation took place on more than 8,000 women from Emory University with some nice diversity in both of them. And in both studies, overall risk prediction improved with prior mammograms, and this is a result on the external validation cohort, where basically the addition of prior mammograms increased the AUC to 0.80 versus the 0.74, which was on a single prediction on a single time point. So what this study further shows here is an additional further validation of this model, specifically on a large cohort, Canadian cohort of women with dense breasts, Bidar's C&D, and the predictive capacity of the model remained in similar levels with an AUC of 0.77, which showed good generalizability. And also the team reported on further analysis that showed that only 5.7% of the cancer-free women were placed in the 2 highest risk strata defined by their dynamic risk score, and 38.6% of women who eventually developed breast cancer can be found in the 2 highest risk strata, and that corresponding to 5.7% of the population with dense breasts. So I hope that with this discussion and those great results that we reviewed, you would agree with me that these studies further build on the current literature that shows a promising role of AI and breast imaging in several key applications in screening and prognosis. I think we saw very nicely that all studies emphasize the need of independent validation. We saw that in all abstracts, as well as the need of having large multi-site data with diversity. Certainly racial diversity, I think, remains as a key component, particularly we have seen it a lot in some screening like application of AI, but not as much in the evaluation and validation of prognostic models. So I'm hoping that we would start seeing more of that in future studies. We have been seeing also that the complexity of the AI models have been increasing. For example, with this multimodal transformer. So this certainly brings in practical considerations in clinical workflow and how we deal with missing data and the complexity of all those multiple imaging modalities. And certainly, I think an important point of discussion is the durability of such models. We saw that, yes, independent validation is important, racial diversity, and so forth, but once we have a strong model with some good chance of generalizability, how we keep testing about and monitoring the performance of those models over time and in dynamic clinical settings that might involve different vendors, evolving imaging acquisition protocols, and so forth. So thank you so much for your attention. I look forward to a productive discussion.
Thanks, Aimilia. Again, a wonderful description of all the individual presentations and the context. Maybe we can go through a round of introduction with the presenters starting at the end and coming this way. Yeah.
I'm Reshmi Patel from the University of Texas at Austin.
Yan Qixu from New York University.
Poornima Saha, breast medical oncologist at Endeavor Health in Chicago.
Joy Jan from Washington University, St. Louis.
Great. Any questions from the audience? Yeah. Please go ahead and identify yourself and ask your question.
Hi, my name is Karusha. I'm with Radialis, a PET imaging company. And I was wondering for the speaker who presented on the multimodal study, if they have any experience with PET as part of the research that you did.
So multimodal study, PET involved at all?
Unfortunately, we don't have any PET images so far.
That's all right. I'd love to speak with you after.
Yeah, I will comment that these are all very high-resolution structural images. In PET, we get a lot more molecular information, but a lot less structural. So the models probably have to be adapted a bit. So I wanted to open up a question to the whole panel. I think traditionally when we think of AI in breast imaging, everybody thinks, well, this is the way you're going to replace the radiologist and do the diagnosis. But pretty much all of these abstracts had in common that in addition to possibly aiding with diagnosis, they were all looking at prediction and prognosis. And I wonder if we could maybe go down the line and comment on how the current approaches are beginning to work both for detecting breast cancer, but also predicting how it will behave. So maybe we can start on your side and then just move down the line.
Sure. The prognostic models are currently already implemented in clinics. For example, the therapeutic score, the Gale model. We know that there are well-established guidelines right now for what actions we need to take for women that are placed at some high-risk threshold, right? Like, for example, ASCO has a 3% absolute risk 5-year guideline and actions that can be taken for the woman. So I think alongside the radiologist assessment, if we can implement this clinically, it'll benefit the woman, substantially, because given that, there are actions that can.
So you can not only find the cancer, but actually, in essence, for free, without taking more imaging, predict risk.
Exactly.
You want to provide a medical oncologist perspective on that, yeah.
And maybe from my standpoint as a clinician, I can comment a little bit on the prognostic value of some of these tests as well. We have several commercially available genomic assays available, but I think this is something that is very promising to be something complementary to these tests. As a clinician, often having these discussions in real time with our patients, I think this is potentially very patient-centric to be able to offer a prognostic test, which we can get in real time without the need for tissue, to be able to have some of those discussions and shared decision-making.
Thank you.
I can talk about one application of such model. For cancer detection model, what we can do is to use this model in a triage process. So our model is very good at predicting negative cases. That's because we have much more negative data than positive data. So what we can do is to identify those negative cases and triage so that the radiologists don't have to look at them. And they're like absolutely negative cases that can largely reduce the workload of radiologists. That's one application. Another application can be the CAD system. So our model, like this type of AI model, not just our model, can provide like the specific locations the AI detected on the mammogram or ultrasound, not ultrasound, or MRI, and then just tell the radiology that this is what the model see and help the radiologist to maybe get more accurate result.
Yeah, I love help, but the number of images we now have to read is huge. So to the extent that can guide rather than replace the radiologist, that's a friendly message all around. Poornima, do you have comments on that question?
Yeah, it is similar comment about how this type of predictive modeling can be used as a tool for radiologists. So from the perspective of mathematical modeling in particular, one of the ultimate goals would be to be able to predict how a patient is going to respond to different treatment regimens, and then potentially be able to present that to the radiologist as, like, here's an array of treatment regimens for potential changes partway through a patient's treatment course.
Yeah, and I think it's very exciting to show that you can predict everything from the likelihood of responding to a particular type of treatment to the likelihood, if you're negative, that you might be positive one day. This is great. Over on the left, question.
Diana Mandras, patient advocate. I want to make actually 2 comments. First, I want to congratulate the team. I'm very excited about this model coming to the market and maybe available to the cancer centers, especially because, and I can talk from my experience, I had different images from different centers, and it's very hard for my oncologists to bring together all the information that's coming from different centers and maybe come up with clear conclusion. So I think that would be a great way to integrate multiple images, PETs, MRIs, and CTs, and for different centers. And then the second comment, as you release this first round, the model, first version, I hope to see that for the next model, there will be a differentiation between the type of breast cancer. And I'm speaking from the lobular perspective, since it manifests slightly different and it's hard to see it visually.
Thank you for that question. And let me guide that second question a little bit. You will have different forms of biology that will be coming up in these tumors. And open to the panel, to what extent can that biologic information be brought to bear? If you know somebody has lobular breast cancer, have those made it into your models in addition to into other imaging and clinical, and how do you think about that?
I can comment on our study looked at specifically early stage estrogen positive, HER2 negative breast cancer, which did include subsets of women that had lobular breast cancer. And I think some of the strengths of these studies is it's really agnostic to that piece because it's able to look at the tumor and the vasculature to model some of these predictive measures.
So I think those are great points. And to the other question, I think there are many challenges in having scans at different places and in different modalities. And some of you spoke to the ability to cross across modalities. And I'm wondering if you can comment on some of the challenges there when we bring multiple modalities into the model, not just MR or not just imaging. What are some of the challenges that you faced in trying to bring information into your model across different imaging methods? I realize that's a tough, unfortunate question at 8 o'clock in the morning, but are there some particular features that make that possible or not possible? What are the barriers to being able to integrate across different types of imaging?
I think for my study, the most difficult part in incorporating different modalities is actually how we have like so many images, but some modality we have more images over the others, for example, MRI. And if you give the model all those information, the model can very likely ignore the small amount of data, for example, MRI, and just focusing on maybe mammogram, because it's a large amount of data. I think that's the most difficult part. I'm not a medical expert, so yeah.
I think one of the technical challenges is not everybody does it the same way, and perhaps MRI, which allows you a lot of personal freedom, may be the one that has the most variability. One final question is, many of you spoke to the importance of the availability of data at your center. There were some that were taken from public data. As AI experts, would you like to comment, I think, to this audience on the importance of having data available to you to test your models? Aimilia, you're welcome to talk to this as well. Part of the reason I bring this up, I think it's underappreciated how important it is to make these data sets available and to have them present from institutions to be able to facilitate this type of work. So, Aimilia, you're welcome to comment.
Sure. So I think I totally agree about the importance. And I think oftentimes it's also difficult to appreciate how much effort is needed to put this data together, not only resources, but also the expertise of knowing the modality, all the internal procedures to make it publicly available. So it's a lot of work. And that is really worth the effort because we need those, definitely need those tests for benchmarking to be able to compare AI models, especially, as more and more arise for those applications. Very important for regulatory approvals and continuous monitoring of AI. So I think it's a huge part of our work, all of us who work in the AI space, and we should definitely be focusing, and putting together a large data set, having as much diversity and representation of vendors, sites as possible, and certainly being able to share with the community towards, together leveraging the power of AI in the field. I think this is very, very important.
Any of the other panelists, quick comment on the importance of data challenges? All right, so with that, we've hit 8:30. I do want to make an unsolicited comment. As a person who started in technical areas, math and computer science, I can't tell you how exciting it is in this very technical area to have a panel of all women up here doing this work. So I really want to congratulate you in many ways, including helping us old guys with the diversity of the field. Very exciting work, and thank you very, very much. So with that, I want to thank all of you for coming here in the wee hours of the morning and listening to imagers and computer scientists. And hopefully we'll have more of this next year. Thank you very much for attending, and you're now released. So thank you. And thanks to all the panelists and presenters in Discussant.